This is Megaphone from Medvale Media. I'm Dave Self. This is where we hand the megaphone to healthcare leaders to share their thoughts, perspectives, and the occasional rant about the always dynamic world of healthcare. It is a real privilege today to welcome a trailblazer in the delivery of primary care, Dr. Kyle Rickner, founder and board chairman of Primary Health Partners in Oklahoma. Dr. Rickner attended and played basketball at Southern Nazarene University as well as internationally. Medical school was at Case Western, followed by serving as a staff physician and a battalion surgeon with the 82nd Airborne, supporting Operation Enduring Freedom and Operation Iraqi Freedom. Dr. Rickner, welcome. Before we get into other stuff, an important question first for you. Who wins one-on-one, Bill Russell or LeBron James?
Wow, that's a great question. So LeBron's going to win that. I'll tell you why. Bill was a great supreme defender, but was often lacking on the offensive end. So I'm not sure he could make enough happen. And LeBron could pull him way out far away from the basket and outside of Bill's comfort zone. So I'm going to give the nod to LeBron on this one.
Okay, how about LeBron versus Michael Jordan?
Jordan. Real quick answer.
Okay.
Nobody beats Jordan one-on-one.
Amen. Well, thank you so much for joining us today, and would love to have you give us a quick rearview mirror look at why you founded Primary Health Partners.
Yeah, so we were introduced to the idea of direct primary care in 2014. And real simply stated, direct primary care has a few key elements. First and foremost, there's no insurance involved in that care environment. The revenue is a monthly membership fee. Second of all, you're taking care of a smaller panel. And third, you're available to them during hours and after hours. And so when we heard about this in 2014, it really just clicked how not only as a practitioner, this could solve so many of the day-to-day frustrations and hassles that physicians were experiencing. But then that speaks to the care model side of it. The business model side of it was actually a true cost containment strategy that could impact local businesses and individuals. And so that was really when we heard that and that clicked with us. It's like, this is something that we have to do. We see a real future here because as we all know, the cost curve in medicine has not been turned down by anything in so many years. And it's just it's a runaway train of growth that is really not sustainable. So that's when I decided I want to wake up and be part of the solution, not wake up and still be part of the problem.
How about a quick by the numbers? How many care providers are there at your organization? How many locations? Give us a sense of scale, please.
Sure. So we started with two of us, myself and my partner, Dr. Robert Lockwood, in one location, and then have tried to proliferate around the state. We now have 12 clinics, so 12 locations and 28 providers in those locations, and certainly feel like we're just getting started. And we've also seen the growth around the country as well. So when we started, there were probably around 400 of these practices in the entire United States, and the numbers are often vary, but it's probably somewhere around 6,000 to 8,000 now.
Sounds like growth is in the long-term plan for you.
Absolutely. We believe very firmly and have had serial confirmation in our clinical care over the last 9 years that what we do is the best way to deliver primary care. And we do it for people from all walks of life, from all backgrounds, all socioeconomic status, and we've seen it flourish. And so we feel a real calling to bring this to as many people as possible, not just keep it for ourselves in our little part of the world.
Well, you touched at the top on the idea of a subscription model. Can you give us a sense of what pricing looks like for the average patient that's enrolled?
Yeah, sure. So you'll see some variation around the country. If you sort of take the country as a whole, the average price is about $85 a month. At Primary Health Partners, we have two pricing tiers, one for adults and one for kids. So on the retail side, meaning those individuals who just joined, it's $99 a month for an adult and $49 for a kid. We do offer some discounts to employer groups that we take care of.
Employer groups, that's a little different twist on what most of these practices probably engage in. Unpack that a little bit for us, if you would, please.
Yeah. So, as I mentioned, we were excited about what the care model could do to be impactful to the patient experience and the physician experience and really enhance that doctor patient relationship. But the business model side of this actually has the ability to be a cost containment solution. And so that gets actually exercised out in managing groups of all sizes and in all insurance situations. So we take care of at Primary Health Partners just under 200 different companies, from the mom and pop shop with 5 employees to up to just under 3,000 employees with a company. And so we work with people that have no plan for their employees, and we are their health plan for their employees. To companies that are fully insured that just buy a product off the shelf and then they'll bolt us onto that product. And then we work with many self-funded companies where we either will embed in that plan or come alongside that plan. Those are actually the arenas where we can be economically most impactful and make a difference and save those companies real money that they can then put back in their business and use it to help their companies grow. So it's a way that we feel we can contribute to not only cost containment in medicine, but actually help companies thrive. I mean, when they see um, increased presenteeism, decreased absenteeism, reduction of turnover. That is just going to help any business thrive. And then, not to mention, reducing their healthcare spend, which, Dave, as you know, is often like the second highest line item in any company is their healthcare expense. So we love trying to do that. You know, you and I both know that healthcare is known for two things for sure. One is it's complex, and two, it's costly. And so we want to try to bring some simplicity and some affordability to that equation and start changing things a little bit. We firmly believe primary care does not have to be expensive. It's not expensive. We've certainly proven that.
Have you contemplated ever doing on-site clinics for a major employer, as an example, a self-funded employer that might want you to actually be on site either full-time or part-time on a specific schedule?
Yeah, so there are direct primary care practices that do that. Um, our philosophy is that we're not going to embed in a business. We're very much in favor of a near site clinic, and the reason is we want to be impactful to the community. We want every clinic to be open to the community so that members of the community, individuals that want to join, or other nearby companies that want to join, have that ability too. So um, that's just sort of a philosophical difference that we made. The other, and I'll unpack that a little bit more. I mean, there's there's data out there that shows some healthcare hesitancy from employees when the clinic is embedded in the place of employment. There's just a certain percentage of people that are not going to go there and not going to access that for certain hesitations and confidentiality concerns. And so we want to be able, and then also a lot of the people that work at the company, that's not where they live. And so we love to be able to provide clinics and locations that may be friendlier for where they live so that those employees' families can even access it. So we like to serve not only the employees, but their families. And a lot of our companies do provide the benefit to those dependents.
It feels to me, being a layperson, like managing a panel in this model could get complicated if every encounter was face to face. So, can one assume that you're leveraging some technology to help provide care as well? Is that something that has played into your business model?
Absolutely. So, um, part of the thing we say is we're kind of old school docs in a new world. Instead of carrying a black bag, we carry a black phone. And so the idea is that availability of that sort of Norman Rockwell, Marcus Welby sort of persona that we all knew to be that community physician connected with those families. But the way we connect a lot now is virtually. So there is an aspect of accessibility and convenience that we provide. So when they have a membership, it doesn't dictate how the encounters occur. Certainly, they can come to the office and be seen in person, and that is sometimes necessary. But we can whip out the phones and do a virtual visit or do a telephone call, and just really do whatever the clinical situation dictates. That's best for the patient, and the patient and the doctor agree this will be a great way to accomplish it. So you bet, Dave. We leverage technology to make sure that we're available.
I think you need to somehow trademark the no black bag, just a black phone. That seems like a pretty
Yeah.
good byline. Before people become patients, they're consumers hoping not to need medical services. What is the mojo that you've got going on to attract and retain your clients?
Well, I think it is really the essence of healthcare, which is the doctor patient relationship. So it's really, really different if you believe that you have a trusted relationship with your primary care doctor. And so we believe that care happens best in the context of relationship, not in the context of transaction. And unfortunately, most of healthcare, as you know, is basically a sick system, not a health system, that's very transactional in nature. And so we're trying to reinstitute, reintegrate, reinvigorate that relationship. So I think the commodity is our caring. And so they feel that care that's based through that relationship. Once you have a great relationship with a primary care physician that's trusted, that's just not something you can just go grab off the shelf anywhere. So you kind of don't want to let that go once you found someone that you really like and can connect with, and they understand you and they know you. It's not only easier for us as a physician to deliver care in that context, it's certainly easier for the patient to receive care.
Let's talk for a moment about the people providing care in your organization. It feels from what you've described as though panel size may be smaller, so maybe the quality of their professional life is better. They don't feel quite as hamstrung by EHRs and administrivia. It's more of a, well, as you put it, old school approach. Talk a little bit about a provider, a day in the life of the provider in your organization. And by the way, the term, I don't know anybody that went to provider school, but we keep using that
Yeah.
term. You have to come up with a better.
I agree. I think we try to stay. We are at Primary Health Partners. We are sort of unapologetically a physician organization. I told you we have 28, but we do have four um, what we would call mid-level providers. So we have two PAs and two nurse practitioners, and they each have a great unique story. But our growth, our model is physician oriented. So a life in the day of the physician at Primary Health Partners. Let's first step back and say, when I left the system, when I left the sick system, where I was transactionally very efficient and very good, and they attributed to me a panel of 3,500 patients. And the definition of that at that time was that I had seen those people at least once in the last 36 months, was how they defined that panel size. That by no means implies that I had really good relationship with 3,500 people, right? So in our care model at Primary Health Partners, we sort of set the ceiling around 800. It varies. You'll see around the country, you'll see some that want to hold it to 4 to 600. Um, what we found is that over time, as your panel matures, as they stay with you, you can bring on other people and be efficient. The reason that's important, and more is not always better. So we've left that idea in medicine that more is better behind, um, and realize that these are customers. We're going to treat them like customers. And so we're very passionate about our customer service at Primary Health Partners. In fact, we actually say we're a customer service company that happens to deliver healthcare. So we have to be accessible, we have to be available. We promise same day, next day appointments when needed. So you have to manage that with that panel size. So just to kind of give you some context. And so it varies. There are different characteristics by panels and doctors, but if you take a physician that's a mature panel, 6 to 800 patients, that doctor is going to see somewhere in the neighborhood of 6 to 10 people a day. On the high end, I looked at our numbers for this year in 2024. My highest active provider is averaging 14 encounters a day. 9 of those are in person and 5 are virtual or asynchronous. And so that is almost exactly half of what she was doing in the six system fee for service world. And so, in addition to that, patients do have access through a patient portal of sorts to where they can either call the office or send a message that the nurse and doctor can respond to, whether it's a question or med refill or whatever. So we do have that activity going as well. But what is not happening is a rush, get to the next room. Most of our doctors work out of one exam room a day, occasionally two. And we minimize wait times often to less than 5 minutes in the waiting room. So we sort of flipped. We say we turn healthcare upside down. So in the current system, you may wait 30 minutes. I'm being generous there. It's often more 30 minutes to get 5 minutes with your doctor. At here, you're going to wait less than 5 minutes to make sure you get at least 30 minutes with your doctor. And so, and because we're not having to pay attention to documentation that has revenue tied to it, that process for the provider is greatly simplified. So, yes, we use an EHR, and yes, we still have the ICD-10 codes in there, but that is for the patient's benefit and the provider's benefit, no one else. And so you can see a simplification of documentation that is more based in common sense than nonsense that is often pervasive in our world. I remember when I was in the system, the patients didn't know it while I was there, but at least half my brain was cycling through to make sure I've checked all the necessary boxes and covered all the necessary requirements for that visit. And so you're multitasking in your head all the time. And so I like to think in our environment, we're super patient centered, where actually that patient can get my focus while we're there because I am really not needing to think about other things. So you can imagine that physician satisfaction and fulfillment goes up, patient satisfaction and fulfillment goes up. When you solve the accessibility problem, when you solve the time problem in the care environment, patients are greatly satisfied. And you know what? That brings a lot of professional fulfillment back to primary care. And we're all aware of the national problem of physician burnout. And in fact, we have physician suicide happen every day in this country. And a lot of that happens because of the moral injury that occurs when I'm trying to do right by you and take care of you and do all the right things. And I've got so many external forces pushing me in the other direction. And that becomes just an exhausting, unfulfilling process for the physician. And that does, no matter how good they are, it is going to eventually affect patient care, and the patients feel it. So it's really hard to get in an environment where the provider, the physician is frustrated, the patient's frustrated, and we expect great things to happen to come out of that. So hopefully a day in the life looks a lot like, not hopefully, we know that that's what it looks like. And so I'm happy to tell you, Dave, that we have all of our physicians are happy and fulfilled. And I think if you ask them, they'd tell you they couldn't imagine doing anything else, or going back to where they came from.
That's fantastic. I do hope that your capital improvement budget can withstand having all of your signage say more common sense, less nonsense. So you keep coming up with these, Dr. Rickner. We're gonna keep calling them out. Since you flipped the script on this, have you attracted competitors?
Um, I wouldn't say competitors. I think in general, in the direct primary care environment, well, first of all, let's just acknowledge there's an incredible national shortage of primary care physicians. Period. Right.
True, very
And
true.
so, right from the get go, the laws of supply and demand are far on our side. And then when you realize that direct primary care is still probably just under, maybe we're approaching 10% of primary care delivery in this country, there's not even close to enough of us to take care of people that need to be taken care of or meet the demand. So I just don't think it's a competitive environment in that way. It's a very collegial environment. There's a lot of um, synergy with practices. As a matter of fact, you know, one of the most fulfilling things that we've done is to be able to take care of some of these somewhat larger companies that have employees not only scattered around Oklahoma, but scattered around the United States. And through cooperative agreements, we have direct primary care doctors all over the country that subcontract with us to take care of some of those employer lives. And to my knowledge, I'm not aware of a health system that can pull that off. And so we do a great job of working together for the good of the patient and these employer groups.
What's the biggest business challenge you've experienced as you have created and grown primary health partners?
You know, that is a great question. I don't think anybody has asked me that directly. Um, so I'm going to answer it from a couple of different angles. Um, the key to our growth and success is physicians. So we have physicians that are very frustrated, unfulfilled. However, them making a transition and a change is a challenge. And so I think helping those physicians meet that challenge and helping them through that transition, we work hard to mitigate the risk for them to some degree. But you know, there's three things that I promise every doctor that we try to have come over and join us. One is I promise them there's going to be transitional risk. There always is. Two, there's going to be some transitional sacrifice. And three, there's going to be fulfillment at the end of it. And so I think getting the physicians now, you might be aware that it varies state by state around the country what it looks like to be able to recruit physicians. This is a sad testimony of the state of healthcare in the US. And I know there's some movements around, but we just already talked about the drastic shortage of primary care around the country. However, a large portion of these physicians are literally held hostage, where in many states, the non-compete statuses keep that physician from being able to even open practice or join anyone else in a very large metropolitan area if they're already practicing there as an employed physician. And so that is a significant challenge. It's a frustrating challenge that we have to overcome. It feels very wrong. There are definitely some movements afoot to change that. So that is a big business challenge. The second biggest challenge that we have is getting in the door and starting those discussions with companies of scale that what we can bring to their benefits program and help them. What it's funny, even though it's the second highest cost line for many companies, the people in charge of those dollars, they, because we confirmed that healthcare is both complex and costly, the complexity of it actually keeps them out of the game. It's easier for them to just hit the renew button and move on down the road,
That's
and they just
exactly
take
right.
it. It's like their broker comes in and says, "Well, listen, we're going to have an 18% increase, but the good news is it was going to be 24, but I talked them down to 18." So we're and those executives, these very smart people, will often just go, "Okay, sir, thank you. May I have another?" And it just continues down the. So getting in and being able to talk with those decision makers and help them make sense. So it's very funny. I love how you alluded to my common sense comment, but even in this context of dealing with a health plan that takes care of employees and dependents and bringing some common sense to that is a big challenge. I I hate to say it this way, but it is the truth. There are profiteers that rely on complexity in healthcare, and getting them away from the conversation and getting them out of the mix is maybe the biggest challenge in that process. And most of those profiteers have gained a lot of confidence from the people that are there, that they are a vendor for. And so people get used to what they know. They get comfortable with misery, no matter what it is. And so change can be difficult even when, so as we try to explain what we do and how it can incorporate to their plan, or even the best situation, which is the funnest thing we do, is just completely revamp and rebuild an entire health plan, and put primary care at the hub of the plan, which is where it should be, where it can be most effective. And so I think finding the physicians, and then going and finding these businesses and having these meaningful conversations. Now, obviously, we've had some success in both of those areas, but that doesn't mean they're not still challenges.
Thank you. We ask our guests to gaze into the crystal ball and give a view of the future. So, can you take a look into your crystal ball and tell us what you see as the future of primary care?
Well, so the journey, the mission, the goal is to normalize direct primary care, where this is not an unusual conversation, that our interview today is irrelevant in 10 years because it's just the way it's done. So I see that what will have to occur. This is the big challenge. Is honestly, the health systems need to get out of the primary care business and leave that to us, the physicians, and let us work cooperatively with hospitals to care for patients the way it used to be. And so that's the journey. That's where we're going. How we get there is expansion and widening of customer acquisition sources along the way. I've mentioned retail patients. I've mentioned the employer groups. What I haven't mentioned to you is we now get patients through an actual insurance company that built an entire plan around direct primary care. So that's going to expand. We also have technology solutions that are brokering what we do to very large employers around the country. So we have technology solutions that are interfacing, that are making a difference. And then people don't know this, but there's actually provisions in the Affordable Care Act for direct primary care. And also in the latest CMS code, there is also Medicare provisions for direct primary care. So there are some people looking into this crystal ball and seeing this model of care going, wow, it could be impactful for Medicare folks, Medicaid folks, and for large corporations. And so it's really a war of attrition of getting into each of those customer acquisition channels while not losing the key elements that I've told you. That's the key. No one gets to own that piece of it. And if I have any say in it, we're going to see a proliferation and widespread of direct primary care to the point of normalization, and the cooperation where healthcare starts at the primary care office, and that primary care office is not subjugated by anyone, so that the decisions can be made that are best for the patient, that are purely patient-centered, and then we can leverage the local resources to serve that patient the way that they deserve to be served.
Really, the primacy of the patient-physician relationship and preserving that is the big takeaway from what I understand.
Absolutely. We've got to restore it first. It's what's been lost. It's what's been eroded to where we're at today. So this process of restoring it and then preserving it moving forward, you bet.
Well, you get the last word. What message will you leave us with today?
Well, I'm very fortunate to have been able to sort of explain what we do, but I want people to hear that, you know, healthcare in America is not only the most costly of any country in the world, and it's not even close, but our outcomes have not tracked along with more spending. So more dollars haven't done it. So we have to, as a country, we have to be willing to step out, take risks, innovate, be willing to change in order to change this, or we're on an unsustainable path. So Buckminster Fuller actually has a great statement that I love. Is that when you see a system that is completely broken, you don't really make it better by going in and fix it. You create a new one that renders the old one obsolete. And so that's honestly what we're trying to do in primary care is change the paradigm completely, create this other. And I believe the rest of healthcare, I've already seen instances of it, are going to follow the path of primary care. I am a huge proponent of independence for physicians. I believe physicians can be the best patient advocates, and I believe there can be great working relationships with physicians and hospitals to improve. And that's where I really want us to get back to. And so I hope that anyone that's listening that's involved in the complex US healthcare system can begin to try to think outside the box and go, this status quo is not okay. It is not okay. We're in a broken system, and everybody has the ability to influence their part of that healthcare world. That's what I'm trying to do in mine. And there are other people we need to be courageous, to step out, to trailblaze, to be willing to be creative and innovative and make those changes. And I would ask any listener or any audience, anybody that would be willing to take up that banner and let's sort of save our American healthcare system before we're at a point where we're forced to do something none of us really want to do.
Dr. Rickner, thank you so very much for investing the time and being with us today. It's been a real privilege to have you. Our guest today has been Dr. Kyle Rickner, founder and chairman of the board of Primary Health Partners. That's all for this edition. Join us next time for the next installment of Megaphone from Medvale Media. I'm Dave Self. Be well.